Good afternoon, everyone. My name is Tara Romanian, and on behalf of Lung Foundation Australia, I'd like to welcome you to this webinar for lung cancer. Through this virtual meeting place today, we are gathering from many parts of Australia, and I would like to start by acknowledging the traditional owners of country and their continuing connection to land, sea, and community. For myself here in Brisbane this afternoon, I stand on the lands of the Yagara and Turrbal peoples. We pay our respects to them and their cultures and to elders both past and present. So in honour of World Lung Cancer Day today, we are presenting this webinar around your pathway through lung cancer care. We have a fantastic panel lined up today with both patients and clinicians here to answer your questions and share lived experiences as well as expert clinical insights. So this webinar will be hosted by the lovely Stacey Allerton, who is one of our patient advocates living with lung cancer. So I will pass it along to the lovely Stacey to introduce herself and lead us into today's session.
Hello everyone, my name's Stacey. I'm based in Brisbane and I work in the community services sector. I'm also very lucky to have 2 stepchildren. I was diagnosed with stage 4 EGFR positive lung cancer in February this year, so I am really looking forward to hearing what our panellists have to say. Before we get started, I'm going to hand over to our speakers to introduce themselves so that everyone joining us today can put a face to the name. If you could please share a little bit more about yourself and your journey to give people some context of your backgrounds, that would be really helpful. I'm going to hand over to you, Anne, now.
Hi, hello everyone. Please excuse my voice for starters because I've had a bit of laryngitis and I've been saving it up especially for today. I'm based in Brisbane and in November 2020, I was diagnosed with stage 2B lung cancer. That turned out to actually be stage 3A lung cancer. I had 3 rounds of chemo. I had at the top right half of my lung removed with lobectomy, and I followed that with 30 hits of radiation, just for good measure to make sure that we had everything under control. I carried along quite okay for like the last 2 years. I've been traveling okay and just dealing with the side effects and all the other bits and pieces that come with having lung cancer. And in just May of this year, I was re-diagnosed with another new tumour on the scar line of where my operation had been. So they were very hopeful that it was just a leftover cell that had gone rogue from my initial lung cancer and it wasn't a spot somewhere else. So I've just finished stereotactic radiation and I'm on the road to recovery. I'm married, I've got 2 stepkids as well and a gorgeous granddaughter who I think gave me the cold, which has given me the laryngitis. So I'm pleased to be here today and I hope I can add some insight to everyone.
Good afternoon, everybody. My name's Janine Shelton. I'm one of the cancer care coordinators here at Toowoomba Hospital in Queensland, part of Darling Downs Health. I've been working in oncology for a very long time, over 12 years, and I've done a lot of different cancer specialties, but I've been doing lung cancer for the past 3 years now. I absolutely enjoy working with my patients, and I've certainly found my niche looking after people with lung cancer and supporting them through their diagnosis and their treatment. I'm a mum as well. I have 3 beautiful teenage children, and that's me. Thank you.
Hello, my name is Kelly. I am a CNC at the Royal Brisbane Hospital. I've worked in cancer care here for over 25 years and specialising in lung cancer, among another couple of cancers, for the last 8 years. I think I've also probably found if I had to pick one tumour stream out of my 3, it would definitely be lung cancer for so many reasons. I'm quite anxious about this presentation today, as I shared with the panel earlier, because I don't know how to tell people who are living with lung cancer about their lung cancer. So I just want to acknowledge everybody that I've had contact with in my 25 years plus of working in cancer care, because today I hope that I will be telling some of their stories and some of their tips and tricks. If it's not the patients, it's the doctors that I've learnt from, and then colleagues and reading and everything. So yeah, I feel very underqualified, and I just want to honour all those people that have told me their stories over the years. Thank you.
Hello, everybody. Thank you for having me as a panelist on this wonderful webinar today. Admittedly, this is my first webinar that I've been a part of, so I'm very excited to take part with you all today. My name is Laura. I'm a specialist lung cancer nurse consultant at the Lyell McEwen Hospital in Adelaide, South Australia. Basically, I'm fairly new to this role. I have been working in respiratory for the last 10 years, as well as bronchoscopy and pleural procedures. And in the last 2 years, I've picked up my portfolio in lung cancer. So I'm really enjoying this so far. I find it very beneficial to work with people with lung cancer and their families. So I'm looking forward to participating with you all today.
Amazing. Thank you, everyone. I'm really looking forward to hearing what you have to share today. We're going to kick off today's webinar with some pre-submitted questions sent in via the registration form, and then on to any questions that people submit through the live Q&A. So the first question that we have is, if I have a family history of lung cancer, what sort of screening or monitoring should I be doing? We will start with Janine for this one, and then Kelly or Laura, feel free to jump in as well.
Thanks, Stacey. So I guess the first thing that we have to say is at the moment, we currently don't have a national screening program available here in Australia, but hopefully, as we've all heard in the past 12 months, that's not far away. It should just be around the corner. So that's very exciting to know. But in the meantime, the best thing that you can do if you do have a family history of lung cancer is to understand what things will increase your risk of getting lung cancer, and then modifying your lifestyle so that you can actually reduce that risk. The first piece of advice that I would say is to make sure that you have regular checkups with your local doctor, your GP, and that they know about your family history. It's important for them to have information on the type of lung cancer that you have in your family and any special genetic markers that have been identified, for example, like Stacey said, her EGFR mutation. Importantly, if you smoke currently, then quitting smoking is top of the priority list, or speak to your GP about the ways that you can look at quitting if you're having a bit of trouble doing that. Be aware and report to your GP any occupational exposure that you may have had in the past from hazardous materials, so asbestos, any of those chemicals, those sorts of things. They can certainly increase your risk as well. Stay healthy, exercise regularly, have a nutritious diet. And finally, and probably the most important thing that you need to know is have an understanding of what the signs and symptoms of lung cancer are and report any unexplained changes to your GP. And do these as early as you can, as early as possible. So these can include things like an unexplained change in a cough, something that's lasted for longer than 3 weeks and you don't know the cause of it, any chest or shoulder pain, new or changed shortness of breath, a hoarse voice that has changed, weight loss, a poor appetite, fatigue, and things like chest infections that are ongoing. So it's just really important to know what those signs and symptoms are, modify your lifestyle to reduce those risks, and keep in contact with your local GP and make sure that you see them regularly. Thank you.
Our next pre-submitted question looks to be for myself and Anne. So what support or services did you find helpful in your lung cancer journey? I'm going to hand over to you to start us off, Anne.
Okay. Well, initially, I didn't have a whole lot of support. When I was diagnosed and my doctors told me this was lung cancer, I wasn't given any brochures. I wasn't told anything. All I was told was don't Google anything. So, of course, the very first thing you do is Google everything and scare the living bejeebers out of yourself. But I just felt like I was the only person in the world with lung cancer, that I had no one to turn to. I had a beautiful support around me with my family, but I felt very, very alone. I stumbled upon a Facebook page, which was the Lung Foundation, the lung cancer page or support page. And from that, just reading comments, someone mentioned the Lung Foundation and the fact that there was specialised nurses. And I went, whoa, what is this? So that was a game changer for me, to get onto the Lung Foundation and actually find that I could talk to a social worker, that I could actually talk to a lung cancer nurse and actually ask questions that were relevant for my life and for how I moved forward with lung cancer. I remember saying actually to one of my oncologists, said, do you guys actually have brochures or anything? And he leaned over and went, oh yeah, I've got this. I said, why don't you hand them out? So maybe he will from here on in, because I like I said, I felt very much alone. And then from that and just doing my own research, I kind of, created my own world around people that I could turn to, people I could talk to, and other patients. And suddenly, I've got a whole new family of people who are in the same boat as me. So that's been super helpful, because they're the people who really get what you're going through and where your headspace is and what you're feeling. So that's been one of my biggest supports, is other patients and the Lung Foundation social workers and nurses.
Yeah, I'd have to agree, Anne. I feel like building your own support network is something that you need to do. And for me, I think the Lung Foundation nurses and the peer support programs have really been invaluable in helping me to feel a bit less alone and also build my knowledge about lung cancer and what to expect moving forward. I'm going to move on to the next question, unless any other panelists would like to offer anything. What role do multidisciplinary teams, MDTs, play in lung cancer care? Laura, I'm going to hand this one over to you.
Thank you very much. So I was quite excited to answer this question, actually, because I've seen from my own personal experience the crucial impact that a lung cancer nurse and also an MDT team can have on the patient's outcome. So first, it's probably important to understand what an MDT team is for each patient. So in a nutshell, it's a network of health professionals or specialists who specialise in lung cancer care, in the diagnosis, treatment and care of patients and their families who have lung cancer. So they usually meet on a regular basis, and this may include respiratory physicians, interventional pulmonologists, radiation oncologists, medical oncologists, cardiothoracic surgeons, palliative care, allied health, and a variety of other specialties who all meet together at one place, one time, to discuss each patient's case and come to the best, I guess, outcome of care for that patient, how to manage them moving forward. A part of that is having a close look at each person's individual case, having a look at their medical history, if they've had previous cancers before, the risk factors that they may have for lung cancer. We have a good look at their scans, including CT scans, PET scans, the pathology that they may have undergone, investigations, and putting all of these things together paints a really big picture of what's going on with each patient, and then we can all collaborate together at the same time to I guess, sometimes argue it out, depending on how each person feels is the best management for each patient. So where I work at the Lamb McEwen, we have them held weekly at the moment. We discuss 12 to 13 patients per week in our meetings, so they're quite busy. And then following the meeting, our respiratory physicians and myself will then touch base with the patient directly to let them know the outcome of these discussions on their behalf, and also liaise with the patient's GP as well. So I guess the most important thing to remember is that the patient should be the core of these discussions at all times. I've found in my experience sometimes the meetings can be a little bit medically driven, so it's very handy to have a lung cancer nurse there to speak up, to advocate for patients and what's important to them and their personal beliefs and wishes. So I guess an example that I can give of that was recently a lady I saw in clinic, a 74-year-old woman who was caring for her husband of 50 years of marriage. He had vision and sight impairments, and she was basically diagnosed with early stage cancer early enough that she was fit to go for surgery. So the team were very keen to push for that for her, being obviously the first line of treatment that's appropriate for her. However, she spoke to me in great detail about how she was concerned about being away for long periods in the recovery period, that she wouldn't be able to support her family. And in the end, we took her considerations on board quite heavily, and she was referred for radiation oncology and SABR based on her own sort of personal wishes and personal situation. I guess the some patients do ask if they need to attend the MDT in person. A lot of people ring us up saying, what time do I come in on that day? Generally, we say to them that we all meet in one place, one time, and it's an electronic form usually, where we get together and discuss the patient and then relay the information back to them. I think that's all I want to add at this point.
Thanks, Laura. Really helpful to have a sense of the clinical structures in place to support us.
Thank you.
Moving on to the next question. This is another one for Anne and myself, I think. How do I manage the side effects of treatment like fatigue, nausea, and skin rash? I'm going to ask you to start, Anne, and then perhaps Kelly can jump in.
Yeah, okay. Look, I've got a few side effects left over from my treatment. I had 3 rounds of chemo, like I said, which you would think isn't that much, but they must have given me, whatever, the biggest dose of whatever, because I ended up with peripheral neuropathy. So I get tingling in my fingers, all right up to my elbows, and my feet give me grief as well, which then cause all my muscles to spasm. So I have regular massage, and I've now started using a TENS machine to try and stimulate something there. But that's one of my worst side effects, is this neuropathy, because I drop things. I think I'm holding something. I know I'm holding something, but I'm obviously not holding it as tight as I should, or I'm holding on too tight. And so that's a bit of a pain. I can't lie, sleep in different ways because my arm goes all numb. So I can be seen roaming around my house at 3 a.m, trying to slap my arm and get some sort of, sense back into it, because it's just tingling and full of pins and needles. And I've been told that now that I'm 2.5 years past chemo, that I'm probably stuck with that. So it has lessened, but it's one of the things that I massage a lot. I do a lot of massage, and I actually even have I do Reiki as well. So I've gone alternate as well as doing, so standard sort of things you would think of. And in amongst all that, it tends to sort of help to have lessened it slightly. So that's one of my things. I was very lucky not to have any skin rashes from my radiation. So but I was given cream in preparation in case that wasn't a case or whatever. I have terrible nerve pain that runs through my thoracic chest wall because of where they cut me open to remove part of the lung. And if I move a certain way, like if I lean through into the back seat of my car, which seems like a simple thing, I can go, oh my God, and should have done that. So I do a lot of stretching. And I do that with my massage lady as well. She's an oncologist massage person who I hunted down, and so I see her every 3 weeks at least to help manage that. But that's I think overall I'm still pretty lucky as opposed to some.
Absolutely. Kelly, or does anybody else have any other insights into managing these side effects? I'm keen to learn. That's for sure myself.
Sorry.
No, that's okay. Keep going.
I've made a big list so I don't miss anything. I guess from the side effects that were listed, I kind of looked at fatigue and nausea intertwined, because a lot of the fatigue, I think if you can focus on well-being, and then that goes hand in hand with appetite, because obviously, calories, energy, that's how we fuel our body. So when patients are going, lung cancer itself, I always say, to me, it seems particularly parasitic. It makes people tired, and it makes people, robs them of their appetite, which is just a vicious circle. Then, if you lose your appetite, you don't want to eat, and then you look for your energy to do things. So around fatigue, it was like rest as much as needed, but not lying in bed all day. So setting probably small little tasks that you could do during the day, but then managing breaks. I know certainly from people who are long-term survivors that I've heard speak over the years, things like if you've got a day out, a wedding or an event or something, a lot of people find they have to rest for a few days before, and then It takes a couple of days to recover afterwards, and not being afraid to tell people about that, because I guess I'll touch on this in the last question about the survivorship stuff, but a lot of the time we say, you know, lung cancer can be the invisible cancer you can't see if you've had a bit of lung cut out, unless, you know, Anne's walking around in a bikini, then we might notice a scar. So yeah, trying to manage your well-being with a little bit of exercise, a little bit maybe of a shuffle around of what your day used to look like, to break tasks down to smaller tasks. Certainly there are plenty of allied health professionals available, like occupational therapists, physios, exercise physiologists, that can help coordinate some of those things. And some of those services would be available definitely in most of the larger public hospitals, but to talk to GPs about the healthcare management plans and what would be available with some Medicare rebate around that. As far as eating, I always say to my patients, small meals more regularly, focusing on calories and protein. So now's the time to have milkshakes and thick shakes with ice cream and cream on top. If you like milk, fortifying your milk with milk powder, because that gives you more calories and more energy, more of the fat soluble vitamins, without more intake, more volume of food. Sometimes a lot of patients report that if they feel like, you know, my favorite is a roast chicken dinner, and that's all you want, and then by the time you've smelt it cooking and you've seen it all dished up, that's the last thing you want to eat. And that can be really distressing for carers, because a lot of the time the one thing people that love you can do is feed you. I'm a bit of a feeder as well as a bit of an eater. So sometimes if you say, I really feel like a roast chicken dinner, but don't be around in the kitchen, or sit outside while it's cooking. If the family then eats smaller meals, because if you look at a family's plate and it's piled high, that can turn people off. So a lot of little just tips and tricks about that kind of stuff. It's hard to have an appetite if you're struggling with your breathing. It's hard to eat if you're struggling with your breathing. Often if you're a bit constipated from pain relief, or because you're not moving around, or from some radiation side effects, you're also not going to feel like eating. So I think it's very much a multifactorial approach to sort of having a think about, could I do a little bit of this and a little bit of that and a little bit of that. The other thing that I guess I just wanted to touch on was pain and pain management, because a lot of the time I have people, they've got pain. I think sometimes if they're on regular pain relief, they're worried that means the cancer's worse than they want it to be. And it's not necessarily. Like, I see people covered in tattoos, and I've got one tiny little tattoo of my son's footprints. He was very preemie, and that killed. And I look at people who were covered and think, how on earth did they do that? So, I mean, pain's very relative to the people. So just because someone's on 20 milligrams of Target and someone's on 10, it doesn't necessarily mean that your cancer's worse or getting worse. And a lot of the time it can be temporary while we wait for other things to work, like some surgery or some radiation or some chemo. So if you're started on some pain relief, I guess being open and honest about what your pain levels are, where they are, what kind of pain they are. If you started on some longer term pain relief, knowing that they can take 3 to 5 days to reach the state in your blood where you're not doing this, that a lot of the time if you're on other drugs like endone and Panadol, those doses may not change for the first 3 to 5 days while you're on the longer acting ones. But then there are a whole lot of other drugs that we use for pain relief, like anti-epileptics, things for nerve pain, and they can take weeks to titrate up. So if you've got pain, don't be afraid to have a conversation with your treating team about it. And I think a lot of people are worried because they've got preconceived notions of what some of these drugs are and do and mean. They're not necessarily forever, and it can be a little bit of hit and miss, and it's all very relative. So we need to have those open conversations. That's probably as much as what I need to say. Thank you.
Stacey, can I just add in that I agree with Kelly, and that's one of the things I did want to say is I do things in small increments, because then I just go, I'm buggered. I've got to have a lot, I've got to have a rest. And I don't actually even have a lie down, because sometimes when you lie down, you wake up and you're still as tired as you were, because it's a different sort of fatigue. It's not like normal people have, where you have a sleep and you go, oh, I feel full of energy now. You're still kind of tired because it doesn't leave you. But I find if I can do something in a block of like a couple of hours, then I just give myself a break. and I just sit or rest, do nothing, and then I'll go and do something else. And that's the best thing for me. And the other thing I found when I was on treatment and I didn't feel like eating, and I knew I had to eat, is I actually got in light and easy meals. So I could then, you know, have a choice. And if I thought, oh, that just turns my stomach thinking about that, I could go and pull something else out. It was less stress on my husband worrying about trying to cook, because he can only do sausages and mash. And I knew I was getting the protein and what I needed for my body to help fuel me and make me feel better. And yeah, I exercised as much as I could through treatment as well. So I've got a great guy at the gym who's looked after me, and he just rearranged everything to sort of work for what I could do. So that's what I else would like to add, if that's helpful.
Can I also add something as well? On top of what everything that Kelly had said, when you're in treatment having chemotherapy or immunotherapy, it's really important to take the medications, the discharge ones that are prescribed for you by your treating doctors as well. They're designed to help prevent or minimize the side effects, and that's so that you can continue treatment. And probably the other thing that I have a lot with my patients is when they're reporting their side effects to us, a lot of people try and downplay the severity of their side effects so that they can continue treatment. And that's obviously, we want people to continue treatment, but we have to make a decision about the quality of life of our patients, and that we're not, as Anne said about the peripheral neuropathy, that we're not going to cause long-term, lifelong problems down the track because we have ignored those side effects. So it's just really important to keep those communication channels open with your treating doctor, your nurse coordinator, and if you've got a really good GP, have regular appointments throughout your treatment and afterwards, because they know you better than probably what we do as well.
We might keep moving then, guys. Don't forget to submit any questions that you might have in the Q&A box so that we can answer them once we get to the end of our pre-submitted question. Our next pre-submitted question is, how do I find and join clinical trials that are appropriate for me? Janine, I'll hand over to you.
Thank you. So I guess clinical trials, it's the new buzzword that everyone's talking about. There's so many different trials out there. The best place that you can start is obviously talking to your treating team, your doctors and your nurses. If there's any trials available locally in your facility, or if, for example, I'm from Toowoomba in Queensland, and we do a lot of work with our large metropolitan hospitals, Royal Brisbane, the PA. So see if there's anything that's available there that our patients might be willing to travel for. Talk about eligibility requirements. You can, the Google word, you can certainly jump on and look at some government websites that they will have information about clinical trials. And also another couple of really good places to find information is Lung Foundation website and also the Cancer Council website. They actually have a resources page. You can go down and you can find lots of information on specific types of clinical trials for different types of cancers. So there's lots of information out there. My advice would be start with your treating oncologist, and because they will be up to speed with everything that's available and what you can access locally and whether or not you'd probably be eligible as well.
Thank you, Janine. Okay, looks like we're on to our last pre-submitted question for the day, which is, what does life on maintenance treatment or after completion of treatment look like? What support will I need? Kelly, why don't I ask you to start and then we can hear from Anne.
Okay, once again, I've made a big long list. This is probably the one I feel maybe most unqualified. So I've taken lots of note to Anne as you've been speaking as well. I must admit, to pass on. I guess probably one thing that I notice a lot would be the fear of recurrence, or the fear of what's next, or the fear about coming back to the hospital, all of that sort of stuff. And I guess I just wanted to reiterate as well, I think, was it Janine that said it, having a really good GP is absolute gold. Having a support person or knowing from your health facility who's your contact person. I often say part of my role is trying to let people live the best life they can, despite what the doctors and the treatment nurses and the treatment people are doing to them. And if that's keeping them away from this hospital as much as possible, then that's what we'll do. I'll often liaise with GPs and talk to GPs, and we'll try and problem solve things to keep patients away from here if possible. But yeah, definitely following the instructions and the follow-up plans as much as you can. So, you know, if you're supposed to have a scan and a blood test every 3 months and then come back, everybody should be getting on with their life and has things to do, but don't put that off for 6 months. If you're going to go away, have a talk with your treating team before or after and work out how you're going to schedule that holiday or that time away or that caravan trip around Australia. The follow-up appointments, for the most part, are totally evidence-based. And so there is a reason why scans are this close together for so long and then this close together as well. Definitely take notes. When you're having follow-up appointments, I know a lot of patients are so anxious before those follow-up appointments. If you find that, you know, you walk out of one and get some good news and you go out and celebrate, but then the next day you're starting the countdown to your next CT scan or your next appointment, then definitely find someone or something that can help you compartmentalize that. I really hope that most of my patients don't live their life through this just constant veil of cancer, and that's probably easy for me to say sitting here with my lanyard and my clinical nurse consultant badge on. But find a psychologist or some therapy or a distraction that you're not living most of your life with that anxiety building up. If you've got someone that can go with you to the appointments, or if not, take notes in the appointments, because a lot of the time those follow-up appointments are 20 minutes long, half an hour long, and there is a lot for you to tell the doctor and there is a lot for the doctor to tell you. And so go with your list of notes or questions or comments, whatever. Get a diary, whatever works for you, write it in your phone, and then take someone with you if you can. Have someone on the phone if you need to. Have someone telehealth in, just ask those questions because you're allowed to. And even if you write a list through there and then go through, is this what you meant? Is this what you were talking about? A lot of patients will see the doctor and race out of here as fast as they can and ring me anywhere from an hour to a week after that appointment to go through what was discussed. And I think that's actually a really important part of my role. And sometimes I'll be in there and I'll be writing notes for them to take away with them if there's a lot discussed. I think looking at life, a lot of people report, you know, things change, goals change, people focus more on what's important to them, family, fishing, whatever that may be. It's a chance to stop and reflect more so than a high functioning career or who's got the best car, all that sort of stuff. But how can you focus on you, and who are the people that will support you, and what are the things that will support you? As far as living with long-term side effects, once again, engaging with teams, be they medical or allied health or spiritual or alternative practices that can help manage that, whether that be massage, as Anne said, or yoga, the people that sit around you at church, or the people that you work with, or your family, or the support groups like through the Lung Foundation. I guess everybody will get support through different avenues, and just allowing yourself the little bit of time to look at where you'll access that sort of support. I had a very, very dear friend of mine, and she doesn't have lung cancer, but she's a cancer nurse who's just been through a different cancer journey. And she's absolutely devastated because she's got a little bit of cardiac damage. And she was a bit of a bike rider, not a professional bike rider, but families would go for long bike rides. And she'd always thought that people that rode e-bikes weren't real cyclists and were a bit lazy. And she's devastated with this bit of heart damage that she can't ride a bike anymore up hills. So now she's considering an e-bike. And I sort of said to her, and maybe it was a bit rude of me, but do you think, 12 months ago, if they'd said to you, we can offer you treatment and you'll probably live, but you're not going to be able to ride your bike up the hill, would you have had the treatment? And she was, yeah, of course I would, but I'm still grieving that I can't ride my bike up the hill. And so I guess that's the other thing, is that it's okay to grieve for what you've lost, it's okay to grieve for what you used to be, but then how can you make little changes, like Anne said, do a couple of jobs and then sit for an hour or two and then get up and do the next few jobs. So looking at people that can support you to find that pathway. Thank you.
Look, all of that I think is I try to follow all of those bits and pieces, but it's very strange being a lung cancer survivor, that when you finish treatment, and I was one of those patients that people would look at me and go, "Oh, you look so well," and apparently, you know, you're supposed to look like you're half dead or something, and so then when I finished treatment, they'd all say, "Oh, you're back to work now." Now it's just not a possibility. And I did have a high pressured, high flying job, and I'm a real estate agent and in high end properties and what have you. So I can't work at the pace that I used to work at, because, you know, I can't pick up all my bits and pieces, and I'll sit at a computer for long and send 8,000 emails because my hands go numb. You know, I can't talk for too long because then I'll start to cough, because I now have a cough that just shows up whenever it feels like it. And I can't run around from an open house to this open house to that open house to that open house on a Saturday and do that. So you suddenly have to, you feel like you're in this abyss of nowhere and you don't know who you really are. You kind of lose your identity, and you have to try and find a way back out to, you know, who am I and what can I do? Because you've got all this knowledge and all this experience, but you just can't do these things because physically it's just not possible. And then mentally that really screws with your head a bit. So you have to kind of get your head around that. So for me, I found that talking to other lung cancer advocates helped, and talking to other people who, you know, are managing work or are doing this, and how are you finding this? How do you fit that in? How does that work? I spoke to my bosses, who have been absolutely brilliant, and they just said, do what you want to do, sell what you want to sell to whoever or whatever, and other than that, we don't need to see you. So I barely go into my office, especially coming out of COVID. I didn't go anywhere near people. So a lot of my work I could do from home, and then I could just kind of go out and do what I wanted to do. So now I'm probably getting a lot more enjoyment out of my job because I'm only working with who I want to work with. So that's a good thing. And and life does change. You know, yes, your family becomes more important. The fishing, the spending time with your granddaughter or whatever it is becomes way more important. And you know, sometimes you go into work and you just feel like giving people an uppercut because they don't get it. And but you know, if I can help teach people that this is how it is now, this is how it looks, and just because I look well doesn't mean that I'm firing on all cylinders. You know, that people just think, oh, you know, I had a bit of cancer, you're over that, and off you go. But that's not how life is when you are a lung cancer patient. So I don't know whether that's making any sense to people, but yeah, you do have that fear also too, is like you're living from scan to scan. You know, initially like every 3 months you've got this 3-month increment of life, and then it's like, you know, this anxiety comes in, and it does exist, and it's true and it's real. So you've got to find someone to support you through that. And that would be either, yeah, if you haven't got a good GP, or if you've got good support within your peer group pressures, like the LC group on with the Lung Foundation has been enormously helpful to me. And being an advocate for the Lung Foundation has also helped me, because I know I can pick up the phone and speak to those other people to get me through that anxiety. But that doesn't leave you. And then when you think, whereas I was 2 years cancer free, I got 3 more years to go, and then I'm at my 5-year mark, you know, because I set my goal, and then bang, you know, you've got a reoccurrence. Then it's like, oh, down another rabbit hole you go again, and you've got to climb your way back out of that and just go through those, you know, all of that, I don't know, all the skills that you've put in place before, you've got to draw on those again. But I find things like every morning I write down 5 things that I'm incredibly grateful for in life, and little things like that help me. Or, you know, even if it's, and, you know, suddenly you look at birds chirping and you think that, you know, you wouldn't have even thought about that as you raced off in your car. You know, you think, look, they're having a great day. Why can't I? So it's just small things like that, which may sound silly, but little things like that really help me. And then even when I'm coughing or my arms and pins and needles, I go, I'm grateful that I can feel pins and needles, because it's a damn sight better than being on the other side of the fence. So I find things like that help me with my own personal support, and helping others is also of big support to me. So paying it forward, I get so much more back. So I think that's a big thing to take on board as well. You know, we all got our crappy parts to lung cancer, but if you can help someone else out, then you feel 3,000 times better, and that helps you in your whole mindset and what have you. They're the things that work for me.
Lovely, thanks, Anne. I really enjoyed your response. Thank you. Okay, we have finished our pre-submitted question portion of the webinar. So now we're going to move on to some of the questions sent through the Q&A box. So please feel welcome to send your questions through while our panelists are with us today. Once again, please remember that the questions should be of a general nature, and any specific questions will need to be referred to your treating doctor. Our first question that I'll hand over to the panel is, how do you know if your case has been presented to a MDT if you're at a private hospital, not public?
I may jump in and just answer this one the best I can. So what I wanted to mention earlier is that every patient should be given the opportunity to be discussed at an MDT meeting. Unfortunately, that's not always the case, and I think the Lung Foundation Australia actually did some research back in 2018 which demonstrated that only roughly half the amount of patients are being discussed that should be. Within my experience, we do receive referrals from private physicians requesting MDT discussion within our institution. This can either be done as a direct referral to a respiratory physician or to the department itself. Your GP can also advocate for an MDT discussion on your behalf if you are being treated privately, and request that you be discussed within the public forum MDT environment. So the opportunity to have that is definitely there for every person, and should be, rightly so as well.
Thank you for that, Laura. That's really helpful, because as a private patient myself, I don't know that I've ever had the opportunity to connect with an MDT, or that my situation's been discussed.
Yeah, your GP should be informed of any outcome as well, of discussions that do occur. They'll be sent documentation that they can go through with you.
Oh, thank you. Good to know. I've got another question here that says, is exercise recommended for lung cancer patients?
The answer to that is definitely yes.
Most definitely. Most definitely.
That's exactly right. Yes.
Not overdoing it, not overexerting it. And a lot of lung cancer patients have trouble with their breathing. You don't want to have yourself having a coughing fit that you can't recover from, but most definitely getting out and doing some gentle exercise or whatever is tolerated, and as often as is tolerated. And I guess, with lung cancer in particular affecting lungs and breathing, maybe if it's a short walk in the morning and something else in the afternoon, just breaking it up, like we've already spoken about. But yeah, most definitely.
And just to add on to that, I certainly don't have access to exercise physiologists in my hospital, but linking in with an EP is actually another way to encourage that gentle exercise and learn what your barriers and what your limits are. So you can certainly speak to your GP and they can do a GP management plan to an EP. Some public hospitals do have access to these guys as well, and they are a wealth of knowledge around managing what you would like to achieve on a day-to-day basis.
Can I just add in that when I got through treatment, especially after having surgery, somebody lent me a treadmill, and if I could walk for 5 minutes on that treadmill, it was like happy days. But I had an exercise physiologist, and I also had a physio, and both of those I got to speak to a trainer I worked in with at the gym. So he knew then when I wanted, because that was my goal, was to get back to going to the gym, because I was super fit before I got sick, and so they all worked in together to sort of slowly get me to where I was. And I went from being able to walk maybe 5 minutes on a treadmill to this morning I got up and did a blitz class. So, I don't do it at mega pace, but I still do it. And that's a 50-minute session. So it's possible, but you just have to be patient with yourself and just plug away little goals, and you'll get there.
Okay, thank you. We've got a couple more questions that we can squeeze in before we finish off today. The next question asks, when would palliative care be helpful in the lung cancer journey?
I'm happy to jump in and answer this the best I can a little bit. So people automatically, I think when they hear the term palliative care that means that the end of their journey or the end of life, which isn't always necessarily the case. In our institution, we aim to refer patients to palliative care team earlier in their journey if we can, mostly to assist with their symptom management. So palliative care are fantastic at intervening, jumping on board with patients and their families to discuss how to manage breathlessness, anxiety, pain, and to basically just liaise with the family and being an ongoing support to them, usually within the community, where the patients and their families can touch base regularly with that palliative care team and ask for advice, ask for guidance on medications and side effects and those sorts of things.
And I would reiterate that palliative care is very much about symptom management. It's by no means just end of life. Unfortunately, that's what people think when they hear those magic words. And people can be involved with palliative care for years, and people can have like an acute involvement with them while some pain relief and breathlessness gets sorted, and then they might fall to the background a little bit, as in there when you need them. It's not all about palliative care units. They're few and far between here as well, and the majority of the palliative care work is done in the community or as an outpatient setting.
And I might just add also to that I'm here in Toowoomba, but I have a lot of my patients that live very rurally and remote. I have patients that are 8-9 hours west of me, and their support in their local hospitals and GPs can be few and far between. So we actually have an outreach palliative care service that looks after all of our rural patients, and they are an excellent resource. They have video conferencing that links in with the patient, the GP and the community health nurse in their local area, and they actually provide, sometimes I feel they provide a better service than if you are sitting in the same room as the doctor with you. And the symptom control is I think probably the most important part of that. I always tell my patients that oncologists are very good at prescribing Targin and Endone, whereas the palliative care doctors, they have this whole other world of access to pain medication that's so better tolerated than the good old-fashioned couple that we talk about. So we also refer early to palliative care, and certainly if they're in a rural community, I like to link them in early. Again, they might only speak to them once every couple of months, but it's that extra support that they can get. Thank you.
I think our last question might be this one from Anita around how often should a multidisciplinary team meeting happen?
I can try and answer this one. If you're talking about how often should a general lung cancer MDT happen, well, I'm the same as Laura. We have one every week here in Toowoomba. But if you're talking specifically about you being presented at an MDT, it depends, obviously, upon diagnosis and discussion about treatment recommendations, but it can be if there's a change in your symptoms from your treatment, if you've had some new restaging scans and they're concerned about disease progression, or if they're wanting to look at sort of changing treatment types and wanting to have that sort of round table discussion about what the best movement forward is. So it can vary. I have patients that are discussed every couple of months, and I have patients that have only been discussed once. So it's very different for everybody.
Hi again. We also have our lung cancer MDT every week, and it's over full every week. But then we have a lot of patients that we discussed from all over Queensland. Just one other thing to add, though, is we also have patients who don't actually have lung cancer, but something has shown up in their lung on a scan. So colorectal cancers and melanomas and gynae cancers, anywhere, if there's something in the lung and we want the opinions of the lung doctors and the imaging experts and the pathologists, and they'll be put onto our lung MDT. And we also have a lot of our lung cancer patients added onto other MDTs. So, you know, brain mets is quite common in advanced lung cancer. And so a lot of those patients will be discussed at the neurosurge MDT. And then within our cancer care office, we share those around with each other, or because a lot of them are on Teams now, sometimes I can just jump in and listen to my patients being discussed as well.
Another question we have is, can people improve their breathing ability by any breathing exercises?
Okay, yes. I'm not a respiratory nurse background, but most definitely there are different rehab programs, and I'm sure the Lung Foundation will have some information on this. But there are a lot of things around breathing. Sometimes it's medication, so sometimes simple things that we'll prescribe, like some liquid morphine, just to help relax everything. Sometimes the OTs can help with positioning. Even things as simple as just having a fan and an air source close by can help with breathing. So yeah, there is definitely things to help improve breathlessness.
Thank you for that. I think we've got one last question. Perhaps everybody on the panel might have some thoughts about this. We have a question about whether there are any reputable sites regarding new cancer treatments, both medical and holistic alternatives, for example, diet and supplements that have been trialled or known to help with killing off cancer cells.
I think the most obvious is probably go to the Lung Foundation Australia website. They are the source of so much awesome and excellent information, and I go on it all the time because there are questions that my patients ask me that I can't answer. So definitely, yes, there are, and it's not all just medically based. They do talk about natural therapies, and Cancer Australia is another really useful website that you can go on as well. It's just about finding those reputable websites that link in with government or have some sort of a medical background with them as well. So yeah, that's where I would be sending my patients.
And I think it's really important that if you are undertaking any alternative or natural therapies, to communicate that to your treating team. You know, just say you're going on a diet where you only ever eat lettuce. You sort of need to let your treating team know, so that when they're looking at your bloods, they understand why your potassium and your magnesium and your sodium, etc., all out of whack. Sometimes some of the alternative medications that people take, even something as simple as like maybe some evening primrose oil, can block some of the mechanisms of action that some of our systemic treatments need to get in and kill the cells. So it's really important, if you are taking anything, vitamin C, anything, just to let your treating team know, so that a pharmacist or someone who knows can do a cross check, and then we can know if they're blocking our mechanisms of action, or likewise we can know if your liver enzymes are up a little bit, what is it due to? Is it due to what we're doing? Is it due to disease, or is it due to an alternative therapy? So just being open in that communication so that we can get the best outcome for you.
All right, everybody, thank you so much for your participation today. I think that's probably all the time we have left for questions. I would really like to thank the panelists today. I feel a little bit more comfortable with the path ahead, hearing some of your advice and thoughts about what else I can do to improve my outcomes. I'm going to hand things over back to Tara to wrap up today's session.
Thank you so much, Stacey, and thank you as well to our panelists. We really appreciate you giving us your valuable time today. It's been a pleasure to have you with us. I myself have learned a lot from you all, and I think our participants today would also share the same sentiments. The space has really provided some inspiring insights, so thank you. So as mentioned by some of the panelists already, Lung Foundation Australia does offer a few different services for people living with lung cancer and their families and carers. So we do have a lung cancer support nurse service, which provides evidence-based information and guidance regarding diagnosis, treatment, symptom management, wellbeing, and relevant support services. This is a telephone-based service, so it's available to patients and their immediate carers. And if you would like to connect in with the nurse or find out more, you can reach out to our Information and Support Centre via the number or email on the screen, so 1800 654 301 option 3. You can also visit our website via the link on the slide, lungfoundation.com.au, to find more information and resources on lung cancer as well that has been mentioned throughout the webinar. Also, that's been mentioned is our peer support services. So there are a few options available. We do have a lovely online support group community that's been shouted out a few times today. That is a really vibrant space. I've seen the group there. They are really well connected and have regular meetings as well through Zoom. So it's a lovely space if you would be interested in joining. Again, reach out to our Information and Support Centre. We do also have another service, which is a one-on-one telephone-based peer support service that matches you with another peer living with lung cancer. So if you're interested in that, then you can reach out to the Information and Support Centre to find out more. But that brings us to the conclusion of today's webinar. So thank you everybody for joining us. We hope you found this webinar useful in answering some of the key questions around living with lung cancer and learning more about the pathway of care. So have a lovely afternoon, everyone, and take care of yourselves and each other. Bye for now.